Hello everyone, I am Dr. Arik Delacruz. I'm an ENT, head and neck surgeon from Iloilo City. And today I am going to talk about the midface. So where is the midface? The midface refers to the facial skeleton below the frontozygomatic, the frontomaxillary, and the frontosuture lines, excluding of course the mandible. So the midface will include the following bones: the maxilla, the nasal skeleton, the zygoma, and the orbital rims. In this illustration, the green area right about here is what we call the cranial vault, this one. The red is the skull base, the blue one is the mandible, and the yellow one is the midface. So by definition, the midface is any bone below the frontonasal suture. This is the frontonasal suture. The frontomaxillary suture. This is the frontomaxillary suture. And the frontozygomatic suture, which is over here. So it is all the bones below those suture lines, excluding the mandible. So the midface is further subdivided into partitions. We have the central midface partitions, further divided into the upper central midface partition, or UCMP, the intermediate central midface partition, or the ICMP, and the lower central midface partition, which is the LCMP. And we also have the lateral midface partitions over here, which is comprised of the zygoma and the zygomatic arch. Here, we'll see the lateral midface, which includes the zygoma, this is the zygoma, and the zygomatic arch. The orbital surface of the zygoma, like here and here, are also included in the lateral midface. Lefort and midface classifications. René Lefort used to classify midface fractures into three types: Lefort 1, Lefort 2, and Lefort 3, based on his experiments on banging heads of skeleton. The AOCMF subdivision is very similar to that of Lefort's. Lefort 1 is similar to the lower central midface partition, fracture that runs from the most lateral point of the piriform aperture over here to the foot of the zygomatic crest is around here. So this is the Lefort 1. Lefort 2, on the other hand, is a fracture pattern that runs across the central midface. This is the central midface, with the inclusion of the upper, the intermediate, and the lower central midface partition. So this is the Lefort 2. Lefort 3 also involves the upper central midface partition, but also includes already the lateral compartment. We now talk about the internal orbit and the orbital walls. So this is a picture of the orbit, and this is from the left orbit. As you can see, this is the zygoma, and this is the nasal bones. The central red shaded area over here is what we call the apex, and the apex is part of the skull base. And we have four walls. We have the superior wall, we have the medial wall, because this is the middle side, we have the lateral wall, and we have the inferior wall, or the floor. The superior wall, or the roof, is still part of the skull base, but the rest of the walls belongs to the face. So this is part of the facial skeleton, and the facial skeleton over here. Knowing the midface and its partition will make us describe the fracture better, or at least its specific location. So this is important when we have to communicate the fracture to our colleagues or to our team. So it is not only that we have to name whether it is a central midface fracture, a lower central midface fracture. We also further name them appropriately by describing its fracture morphology. So we can describe the midface fracture more, whether it is single or multiple, whether it is simple or complex or multi-fragmentary, whether the fracture is open or closed, whether it is displaced or not, or if it's mobile or non-mobile. In dealing with midface fractures, we must iron a few things out first before assessing such fractures. In dealing with trauma patients, we should first do the necessary advanced trauma life support protocol and assess the patient for airway, breathing, circulation, disability, and the environment. The whole ABCDE thing. Stabilizing the patient takes precedence over the management of craniomaxillofacial injuries. We should also do a proper history taking, including but not limited to the nature of trauma and presence of foreign bodies such as bullets or dentures. We should also do a full examination of the head, eyes, ears, nose, throat, and neck. You can also add here examination of the dentoalveolar structures. Basic assessment of the eye and visual acuity is also very important as the eyes are positioned comfortably in the midface. Tests for the eyes will include acuity testing, visual field testing, extraocular muscle mobility, globe position, pupillary reaction, and relative afferent pupillary defect or RAPD. Cranial nerve examination is also a must, especially looking for paralysis of the cranial nerve 7 and paresthesia that involves the trigeminal sensory nerves or cranial nerve 5. After you have done all this, you can proceed to fracture palpation. In fracture palpation, we first palpate the infra and supraorbital rims as shown in the illustration. So you have to feel if there are breaks in the rims, and we also palpate the bones in the nasal area. We also palpate the zygomatic complex and the zygomatic arch. If there are loss of projection or width, here we test the mobility of the maxilla. So with one hand stabilizing the head of the patient, the other hand goes intraorally and palpate whether the lower central midface is mobile, and this will test for the fourth one. This is followed by testing the mobility of the central midface, including the upper, intermediate, and the lower. And we will know if this is a Lefort 2 fracture. And lastly, this palpation technique will test for the mobility of the whole midface, and this will tell us if this is a Lefort 3 fracture. Imaging. CT scan with 3D reconstruction is the gold standard for assessment of fractures, and the advice protocol is a complete CT scan of the skull with 2 to 3 mm thickness. The CT scan slices can be reformatted in the computer to produce a 3D reconstruction. Alternatively, you can just obtain the CD from them and reconstruct the 3D view using a software in your laptop or even in your tablet, and you just have to look for the DICOM readers. There are free DICOM readers right now. You can just download it in the internet. There are tons of resources in the internet where you can just download DICOM readers for free, and even on Android tablets, it is also for free. So whenever you do your surgeries already, you can bring your laptop or your tablet inside the OR, and you will have a reference of the fracture that you are dealing with. So how about x-rays? So CT scan has long replaced the use of conventional x-rays in fracture patients. X-rays underestimates the extent of injury as well as the degree of fracture displacement. However, x-rays can still be useful, especially in quick localization of foreign bodies like dentures or tooth fragments, as well as documentation of plate and screw placements post-op. How about MRI or ultrasound? MRI and ultrasound better detect soft tissue problems but not bone. So it is not so useful in fractures. However, it can detect soft tissue problems like problems in ocular muscles or hematoma. Planning a midface fracture. So when do you repair fractures? So primary fracture repair is limited to 2 weeks. Beyond this time, it is already considered delayed fracture repair. And delayed fracture repair, there's a different protocol, and it is called a post-traumatic fracture reconstruction. It should also be emphasized that midface fractures may also involve neighboring structures like the skull base and the orbit, as well as the ear. As such, the expertise of different specialties like neurosurgeons, anesthesiologists, maxillofacial surgeons, radiologists may be needed to achieve an optimal outcome of trauma treatment. Once the patient is cleared by everyone, you are ready to repair. However, there are instances wherein you must expedite the scheduling of your repair. You must schedule right away if you have a patient with the following scenarios. First, if there is partial or complete visual loss, and this will mean that there is already optic nerve trauma. And in your PE, if there's severely increased intraocular pressure, if there is acute space occupying lesion like a retrobulbar hematoma or emphysema, if there is severe shift of orbital content, if there is entrapment of eye muscles, particularly in pediatric patients, and if there is severe nasal or oral bleeding. All of this scenario, you might want to consider the timing of your repair. The next planning that you should do in mid-face repair is the planning of your airway. Mid-face fracture involves general anesthesia, and the type of airway should be appropriate to allow adequate access. Because stabilizing the maxillomandibular unit during repair is almost always done, an airway away from the oral cavity is preferred. Choices are nasotracheal intubation, so this bypasses the MMF you have on the maxillomandibular unit, or you can do a submental intubation. So submental intubation is just a standard orotracheal intubation. However, the tube is passed through a small incision through the oral cavity floor. So this end of the tube will be passed out over here. So you can still do your MMF, or you can just do a tracheostomy to bypass everything else. After planning the airway, one should plan on the goals of fracture repair. After planning the airway, one should plan on the goals of your fracture repair. And the main goal is to achieve correct anatomical repositioning. This will involve correcting the fracture into the pre-injury state in terms of dental occlusion here, pre-injury width, pre-injury height, and pre-injury projection. So you must remember these 4 dimensions when doing fracture surgery, so you won't miss one over the other. And your repair is more of a multi-dimensional one. So we can see here a pre-op photograph of a severely fractured patient. This one. So he has problems in occlusion, in the width, okay, also the height, and also projection, okay, over here. So these 4 dimensions will guide you to your repair. It would also be helpful if you have a pre-injury photograph of the patient to guide your repair. After planning for the correct repositioning, one must prepare to reestablish the core supports of mid-face skeleton, which we call buttresses or support pillars of the mid-face. You see, the skeleton of the face is made up of many bones, such as the nasal bone, the ethmoid bone, the sphenoid over here, the maxilla, the zygomatic bone, etc. And this bone actually merge to create a facial skeleton with a building-like characteristic with its walls and structural framework. This structural framework is what we call the buttresses. The mid-face can be likened to a tent like this one, wherein the tent will have support, pillars, or tent poles, and everything else like soft tissue and the walls. Or it can be likened to a skyscraper with its steel struts like this one. The mid-face also has that, and it is our priority to reestablish those support in our repair. Let's talk about these buttresses. We have vertical buttresses and we have transverse buttresses. So the first major buttress draws from the alveoli of the frontal teeth to the maxilla and to the frontal bone. The second major buttress draws from the area of the premolars and the first molar to the zygomatic bone, and from there to the frontal bone via the lateral edge of the orbit. The third major buttress draws from the distal maxillary molars over here, then goes into the pterygoid process and to the skull base. So these are the vertical buttresses. And we have also the transverse or the horizontal buttresses, which include the superior orbital rim or the frontal bar, the inferior orbital rim, the orbital floor, and the zygomatic arch. And the last transverse buttress is the maxillary alveolar process and the hard palate. So this can be summarized in this figure. So we have 3 vertical buttresses of the midface, 1, 2, and 3. 3 horizontal buttresses. We have the frontal bar, inferior orbital rim, and the alveolar process or the hard palate over here. Repairing fractures the midface, especially those who have multiple fractures, can be quite overwhelming. There are two options for sequencing your repair. The first option is to reestablish the maxillomandibular unit, the first major step of the sequence, which means we have to start repairing the bottom. And after reestablishing the maxillomandibular unit, we repair the lower central midface partition and up. This is sometimes called the bottoms-up approach. And the second option is going down, where we start repairing first the calvarium or the cranial vault, working in a caudal direction, also known as a top-down sequence of repair. Take note that in the second option of sequencing, reestablishment of the proper maxillomandibular unit is still very important, but it may be achieved later in the case, not unlike the bottoms up wherein you start here. So let's talk first about the bottoms up approach. So the most important concept here is the reestablishment of the maxillomandibular unit, and this is the first priority in bottoms up. This can be done by MMF or maxillomandibular fixation with the following techniques: arch bar, Ernst ligatures, bone-supported devices, including intermaxillary fixation or IMF screws, hanger plates, or inter-arch mini plates. Or you can use interdental wires. Some basic principles in the bottoms-up sequencing is that the occlusion has to be intact. So it means that if you have fractures in the mandible, it must be repaired first so that you will have a good bite and a good occlusion of the maxillomandibular unit. Should there be accompanying condylar fracture, it has also to be repaired first. If the fractures in this area are too complex, then we can base the arch from dental models and design palatal and mandibular lingual splints to reestablish the arches. Now that you have already established the maxillomandibular unit, you can actually do the midface repair in a top-down sequence. So the bottoms-up sequence just tell you that you should start first with the maxillomandibular unit, but thereon, you can actually do the top-down sequence. In the top-down sequence of repair, reconstruction starts from above, which is the cranial vault. It should be noted that the repair should start with the most reliable reference structures and on the side with the least comminution. As such, there should be attempts to address any significant calvarial, frontal, and orbital roof fractures. Then, one should reestablish the lateral partition, which is the zygoma, followed by the orbital rims, because this should establish the correct facial width. With the width reestablished, repair of the upper central midface should follow. Any naso-orbito-ethmoidal and nasal fractures are ready to be repaired at this point. Then it is followed by the lower midface or the Lefort 1 level to establish the facial height. The last fractures to be reconstructed are usually the orbital walls and the floor. This one. And once the lower midface is already stable, MMF can be then reestablished. And here lies the difference from that of the bottoms up, wherein you repair from above going to the lower midface. Then once everything is established, you must do the maxillomandibular unit. Approaches for midface repair. The objective is always to achieve good reconstruction and a lower morbidity when it comes to scars. But the basic concept remains that all fractures should be exposed and be reduced before plating. As such, plan ahead how to approach a midface skeleton with hidden or inconspicuous incisions. Whenever present, the use of existing lacerations is encouraged, but one should not extend these lacerations. So here is the overview of the possible access to the midface. We have here the Carnal Approach, the Lateral Eyebrow Approach, the Upper Blepharoplasty Approach, the Subciliary Approach, the Subtarsal Approach, the Infraorbital Approach, and the Vestibular Sulcus Approach. Also seen here is not a cutaneous approach, but it's a transconjunctival approach. The coronal or the bitemporal approach is used to expose the anterior cranial vault, the forehead, the upper and middle facial skeleton, typically in the Lefort 3 fractures. Coronal approach uses the subperiosteal or the subgaleal planes. The incision usually starts at 4 to 5 centimeters behind the hairline, but it can start as posterior as the upper occiput, especially for male pattern baldness, and it can extend laterally to the preauricular area. The next is approaches to the superolateral orbital rim. The first is the lateral eyebrow approach, wherein you just have to do an incision within the eyebrow, and as long as the incision is placed within the eyebrow hairs, the resulting scar is usually well concealed unless post-op hair loss is occurring. The contraindication in lateral eyebrow approach are those people, or especially women, with a cosmetic eyebrow, and the upper eyelid approach may be more preferable. The second approach, the superolateral orbital rim, is the upper eyelid approach, or the upper blepharoplasty approach, which access the rim to the lateral half of the upper eyelid. So this is upper eyelid, this is the lateral half, along the supratarsal skin crease. However, this may not be suitable to East Asians. So those East Asian patients who don't have that eyelid crease, the lateral eyebrow approach may be more suitable. The skin here is thin, which is good because post-op scar is aesthetically acceptable. So here is a cross-sectional view. So here is a photo where it shows the layer that you have to traverse before you reach the periosteum. Then we talk about lower eyelid approaches. So we have the subciliary, subtarsal. It's lower than the subciliary by a few millimeters. And we have the infraorbital, which is the junction of the thin eyelid skin and the thick cheek skin. And all of this will expose this area of the midface skeleton. Notice here that the subciliary incision can be extended laterally if the patient has a crease or a righted, it's better. These approaches differ in the vertical position of the cutaneous incision. Because of this, the path and the length of the section through the layers of the lower eyelid vary. Among the three, the infraorbital approach has the thickest skin, and a thicker skin is more predisposed to edema and increased visibility of an infraorbital scar. Therefore, infraorbital approach is the least recommended. The subciliary and the subtarsal are more recommended because of their less conspicuous scars. The subciliary approach, or a lower blepharoplasty incision, is just made just below the eyelashes, and it parallels the lid margin about 1 mm, 2 mm. The orbicularis muscle is also entered over here, creating a skin muscle flap, and this skin muscle flap is dissected away from the orbital septum. This is the orbital septum. If you can see over here, this is the subciliary incision. Okay, you enter over here, create a skin muscle flap, and this is the orbital septum. So the dissection should proceed not violating that orbital septum, otherwise fat would just prolapse. Subtarsal approach. The difference with subtarsal approach from the subciliary is only a few millimeters, and it only has an advantage of a rapid approach to the field, considering it is more inferior than the subciliary approach. And that's about it. Marking of the incision line is planned in a natural skin crease below the inferior margin of the tarsus. So the tarsus is over here. The incision is diagonally oriented and starts medially about 2 to 3 mm below the lid margin and courses in a laterocaudal direction. So basically, the technique of creating the skin muscle flap in this approach is same with the subciliary, with the preservation of the orbital septum. In post-op, however, this approach may be complicated by a vertical scar contraction. So some surgeons counteract this by placing a frost suspension suture like this over here and suspend the lower eyelid above the incision to the forehead for at least 3 to 7 days or even more, depending on the post-op edema. The transconjunctival lower eyelid approaches are performed in several ways. It can be transconjunctival, caruncle, or a transconjunctival with a lateral skin extension. And these approaches can access the midface skeleton from the medial orbital wall, inferior orbital, to the lateral orbital rims. The advantage of the transconjunctival approach is the superior cosmesis due to a lack of cutaneous scarring. we have two routes. We have the Preceptor Route. Its plane of dissection is in front of the orbital septum. And we have the Retroseptal Route, which is behind the orbital septum. Okay, you do incision over here. So you'll encounter some fat over here. So you may need to do some retraction of the fat. So let's talk about the Retroseptal Route first, as this is relatively easier between the two. Here is a picture of the conjunctiva. So we have a palpebral conjunctiva and we have a bulbar conjunctiva over here. There is a junction between the two, and this is what we call the fornix. In the retroseptal route, this is the landmark of your incision, the conjunctival fornix. You can just see a line of reflection. So your incision is through this line. Make sure you protect the cornea by using a spatula or even a corneal shield. You can use a blade or even a needle tip cautery. This is a picture of the retroseptal transconjunctival approach. Repair of the transconjunctival approach, you don't have to repair the periosteum. You just have to close the conjunctiva using fast absorbing 6-0 sutures in a running fashion. However, there are surgeons who don't suture the conjunctiva at all, and they have similar results. The preceptal route requires entering the suborbicularis oris preceptal space. So it's the space between the orbicularis oris and the orbital septum. Going to this space, you actually preserve the orbital septum. It is the transconjunctival version of the subtarsal approach, but instead of entering it through the skin, you enter it to the conjunctiva at the lower border of the tarsus. So you have to palpate for the tarsus. After protecting the cornea with corneal shields, you palpate the lower border of the tarsus. It is somewhere in the palpebral conjunctiva. Actually it's over here. So let's talk about the transcaruncular approach. The medial orbital wall can be exposed using a medial conjunctival incision posterior to the lacrimal drainage system along the semilunar fold. The incision is either a precaruncular or a transcaruncular. The concept here is to dissect inside the periorbital soft tissue until the posterior lacrimal crest is reached. Once the posterior lacrimal crest is reached, the periorbita is incised and the medial orbital wall is dissected directly on the bony surface. So a medial conjunctival incision is done posterior to the lacrimal drainage system along the semilunar fold. After the conjunctival incision, the caruncula is grasped with forceps and dissection is done inside the periorbita medially to the Horner's muscle. So this is the Horner's muscle. So medially, vertical incision of the periorbita posterior to the Horner's muscle, the medial orbital wall is exposed. This one is the anterior ethmoidal artery already. The lower and intermediate midface or even the lateral midface can be approached via a maxillary vestibular approach. A horizontal incision or a hockey stick ending through the maxillary vestibular mucoperiosteum is done and slightly above the mucogingival junction. This is fairly a straightforward incision to the midface skeleton. You just have to take note of the infraorbital nerve when you're doing your subperiosteal dissection. So in summary, approach to midface fractures will involve knowing the midface and its many partitions. You have to prioritize advanced trauma life support protocol. You have to do complete head and neck, eye, and cranial nerve examinations. And the best imaging modality is a CT scan with 3D reconstruction. You have to establish your goals for midface repair, and this is guided by knowing the different buttresses of the midface. And you should be able to reestablish dental occlusion, height, width, and projection. One should also plan the repair sequence, especially for multiple fractures. It can be bottoms up, starting with the maxillomandibular unit, or a top-down sequence. So you also plan your incisions to get the best scars. Thank you very much. And if you have any questions, you can email me at this address or just go to my website